Well, as you all know by now that this is dedicated to the cause of community medicine. And right now, we are on a drive to prep up the 7th semester students for their upcoming examination. Well, in the last upload, we discussed about health and concepts of disease, and now we are going to take up one of the most important chapters, that is principles of epidemiology and epidemiologic methods. Before we go into the important questions, the important concepts, it is very important that first and foremost we have a clear understanding of epidemiology itself. The word epidemiology originates from three different words taken together, where epi means upon, demi comes from demos, that is means people, and logy comes from logos, which means study, a study upon people. And if we look up John Lust's definition of epidemiology, we will see he puts it as the study of distribution and determinants of health-related states or events in specified populations and the application of this study to the control of health problems. So, to many people, epidemiology comes across in different forms. To some, it is all about definitions. To some, it is about the different approaches to study the disease in the population. Some it is about testing the hypothesis, developing the hypothesis, or developing the postulates, finding out the ways to combat the diseases, implementing the surveillance methods. So many minds have many ideas about epidemiology, what it is in reality. To know it, let's take a look at this Banquet spread. Well, you can see it's a beautiful table spread with number of absolutely sumptuous dishes spread. And the person behind it, a master chef. But can she really do it with a single utensil? With just a few things? Can she serve that spread? Well, I guess not. For that she needs a kitchen, which is fully stuffed with all the raw ingredients, as well as an array of utensils, in which she cooks up each of these dishes. And funny enough, she can't use every tool for cooking up every dish. Every dish has to be cooked in some specified utensils. Every equipment has to be used for a specified purpose. Only then she can let this banquet be served. Well, so why are we even talking about this? Because this is very similar to what epidemiology does and what an epidemiologist does. So if this urban community and the rural community represents the kitchen, then the epidemiologist is the master chef here. And he too has access to an array of different methods, different ways, approaches, and finds out the frequency, the distribution, the determinants at different levels. He evaluates, he monitors, he diagnoses and investigates the community as large, informs them, educates them, empowers them, mobilizes them, develops the policies, enforces the laws, provides care, assures the competent workforce, and this, in a holistic manner, manages the whole public health. So let's have a small look at the history of epidemiology. Epidemiology is nothing new. It dates back thousands and thousands of years back. Nearly 2005 years back, it was Socrates who had mentioned about this. Then, many years down the line, Captain John Grant, so famous for his bills of mortality, one of the earliest public documents on health. Then this William Furr, and of course, the very well-known face, the father of epidemiology, John Snow. 1854 marked a milestone in the history of epidemiology. And then on, there were studies like this Dolan Hill study, the famous Framingham Heart study, and so on. And epidemiology has continued to contribute to the development of health and prevention of disease in the community as a whole. But what's the bottom line? Then let me quote John Snow. I'm not sure there's a bottom line. Continued discussion and dialogue on these important subjects, a whole range of subjects, is important. So let's get into the question answer mode. One of the most important long questions you need to know are about the time trends in disease occurrence, which you should be knowing with suitable examples, and how to interpret this. Then, of course, the different types of epidemics and investigation of epidemic. And a very commonly asked question is how to define epidemiology. As we all know by now, it's a vast and expansive subject, and it is important to know the types of epidemiological studies. They form almost the foundation of anything you attempt to do in epidemiology. And we should be knowing the merits and demerits of these studies designs as well. At the same time, how to estimate the disease risk in certain study designs, what are biases, how to eliminate them, and so on. Regarding the short notes, it is good to know the hepatitis B vaccine, cold chain, relative risk, incubation period, standardization of death rates, blinding as such, the steps of randomized control trial, AE5, its classifications, and several more explain-whys. And I'm repeatedly emphasizing on the fact that this is not an exhaustive list. This is a comprehensive list of the more frequently asked questions. Now, before we go into the questions again, let us have a very clear understanding of the epidemiologic studies. How to classify them? The question first to be asked is, did the researcher assign exposure? Was any intervention present? If the answer is yes, then it is definitely an experimental study. If the answer is no, then it's an observational study. If in the experimental study, the allocation is random, then it is a randomized controlled trial. If it is not, then it is a non-randomized controlled trial. In the observational study, if there is a comparison group, then it's an analytical study. If no comparison group, it is a descriptive study. Descriptive study is more about hypothesis formulation, whereas analytical study is about testing the hypothesis. Analytical study takes the individual as a unit. Then the different types of analytic study which takes individual as a unit are case control study, cohort study, and cross-sectional study. But when analytical study has population as a unit, then it is called ecological studies. In experimental studies, the patients are taken as the unit. When healthy people are taken as a unit, they are called field trials. And when community is taken as a unit, these are called community trials. So when patients are as a unit, it is either randomized control trial or non-randomized control trial. Healthy people is taken as a unit in experimental study, it is called a field trial. And when community is taken as a unit, then that experimental study becomes a community trial. So we know that all these different types of epidemiological study designs, we should also know the weightage of evidence of these studies. And as you can see in this pyramid, the weightage of evidence increases as we go towards the peak. That is, certainly a case report has much less weight of evidence than a properly conducted randomized clinical study. Now let's understand the difference between longitudinal study and cross-sectional study. In a cross-sectional study, there are several groups like group 1, group 2, group 3, and these different groups are studied at the same time. But in a longitudinal study, there's only one group, but it is studied over a period of time. Now coming to a very important study. This study design is called cohort study. It follows a group of individuals over time to observe the impact of a known exposure. Supposing this is the study population, then there is one cohort that is exposed, and then there's another cohort that is non-exposed. In the exposed cohort, there is a section who are diseased and one who have no diseased. Similarly, in the cohort 2, where non-exposed, there is a section who are diseased, which is much fewer, and there is a section who have no disease, who form the majority. Two of the most notable cohort studies are the Framingham study and the nurse. Well, now let us come to another study design. This is the case control study. Here, the studies begin by identifying a patient with a particular outcome, a specific disease. The patient's exposures are then retrospectively assessed. There is a group consisting of the cases where diseases are present, and there is another group, the controls, where the disease is absent. In the cases, some of them are having the exposure and some where the exposure is absent. Similar fashion in the control also, in whom the disease is absent, may have exposure and may not have exposure. So now that we have a basic understanding of what is epidemiology, what are the different important study designs, we will again go into the question answer mode, because I am not dealing with the concepts in this particular exam ready series, and rather focusing on the question answers. If you want, I'll certainly upload at the conceptual level also, but this is more focused on the question answer and how to face it. But along with, I'll definitely put on this kind of trivias. So now coming to this question, how can you estimate the disease risk in case control study? And what are the biases in case control study, including the process of elimination as applicable? Well, epidemiological investigations like case control study can provide strong evidence linking exposure to the incidence of infection or disease in a population. They can provide estimates of the magnitude of risk related to a particular level of exposure or dose. They can quantify the probability that observed relationships occurred by chance factors, and they also have the potential to control for other risk factors and or confounders of outcome illness being studied. The estimation of disease risk associated with exposure here is obtained by odds ratio, which actually measures the strength of association between risk factor and outcome in rare diseases with low incidence and representative sample. But there can be biases. But what is a bias? A bias is any systematic error that results in an incorrect estimate of the association between exposure and disease. Case control studies are particularly susceptible because of the retrospective nature of the data and the resulting lack of control of the investigator. So let's learn what are the types of bias. Firstly, selection bias. This occurs when sample selection is not representative and it can be eliminated by randomization. Next is the information bias. It can be interviewer bias, which is generated by inappropriate method of gathering information leading to systematic error, and it is removed by using blinding method, which can be single, double or triple. Then another type of information bias is the recall bias. It involves the cases who are aware of their disease status. They are more likely to remember events, and being retrospective in nature, there may be partial or erroneous recollection. This recall bias is affected by the Hawthorne effect, which refers to a type of reactivity in which individuals modify an aspect of their behavior in response to their awareness of being observed. And this is eliminated by careful selection of research questions and choosing the appropriate data collection method. Now coming to the next type of bias, the bias due to confounding. It is a measure of effect of exposure on risk is distorted because of the association of the exposure with other factors that influence the outcome. And how is it eliminated? It is eliminated at the study design level by a procedure called matching, and at the analysis level by using stratification and regression. Coming to the last bias is Bergsonian bias. This is related to the admission rate and often called the admission rate bias. It states that the patients with more than one disease or condition are more likely to be hospitalized than patients with only one disease or condition. If a case control study is exploring the relationship between two diseases, this bias can cause an overestimation of exposed cases in the hospital population. So now we know the different types of bias as well as the methods of elimination. Now the next question is about one of the basics of epidemiology. Define point prevalence. What is the most appropriate study design to estimate the point prevalence of a rare disease? Will that study be able to measure the disease risk associated with exposure? Discuss the relationship between prevalence and incidence, and what are the uses of prevalence. So let's try to develop an understanding of the concept of incidence, prevalence and point prevalence before we go into the answer itself. So let us look at this representation. It shows the number of cases between the period 1st of January 2020 and 1st of January 2021. And it shows there has been total 10 cases in between this whole period of 1 year. The first case, the second case, third, fourth, fifth, sixth, seventh, eighth, ninth, and 10th. So when we will calculate incidence, which are the cases that we will take into consideration? When we are talking of incidence, we'll only talk of case number 3, 4, 6, 8, and 9. Why? Because they are the new cases that has arisen between this time period. So if that is the case, what is the period prevalence? Period prevalence includes both the new cases as well the existing cases. That's why it will include case number 1, 3, 5, 4, 6, 7, 8, and 9. We'll exclude 2 and 10. Why? Because these two cases is beyond the stated period. Now look at the point prevalence. How is it different from period prevalence? Let us take a point prevalence at the 1st of January 2021. So which are the cases that will be included when we'll calculate the point prevalence? See, here the cases to be considered while computing the point prevalence is the case number 3, 4, 7, 8, and 9. Why? Because at that point of time, only these were the active cases. So now that you've understood this, always remember the numerator of incidence is the new cases that occur during a given time period, and numerator prevalence are all the cases present during a given time. So what is point prevalence? It is defined as the number of all current cases, old and new, of a disease at one point of time in relation to a defined population. But when you are talking of this point may for all practical purposes consist of a day, several days, or even a week, depending upon what the unit of time has been selected in the study concerned. And what is the best study suited for this? It is case control study. For studies of rare diseases, for example, most cancers, case control studies offer a cost and time efficient means of accruing relatively large number of cases, thus avoiding prolonged follow-up of large cohorts. Also, the reduced study size of case control study compared to a full cohort study can permit efficient resource allocation to refining exposure assessment and obtaining data on potential confounding factors. So coming to the fact that can disease risk associated with exposure be measured in this kind of studies? Yes, the disease risk associated with exposure may be measured. Although in case control study, the estimation of disease risk associated with exposure cannot be obtained by relative risk, but it is measured with a term called odds ratio. It cannot obtain the relative risk as it cannot measure incidence of cases. The odds ratio which is measured to here, it assesses the strength of association between the risk factor and the outcome. It represents that odds that an outcome will occur given a particular exposure compared to the odds of the outcome occurring in the absence of that exposure. So if we look at this tabulation. Here A is the number of exposed cases, B are the number of exposed non-cases, and C number of unexposed cases, and D number of unexposed non-cases. So what is odds ratio? It is the exposed cases multiplied by the unexposed non-cases divided by the exposed non-cases multiplied by the unexposed cases, that is AD divided by BC. When the odds ratio is equal to 1, it means the exposure does not affect the odds of outcome. When odds ratio is greater than 1, exposure is associated with higher odds of outcome. When odds ratio is less than 1, exposure is associated with lower odds of outcome. Now coming to the last bit, the relationship between incidence and prevalence and uses of prevalence. To understand this, you need to understand this basic picture. Here you can observe a bathtub in which water is pouring through the tap, and also you can see there is an outlet at the bottom through which some water is also going out. So here this visual representation is very similar to the actual relationship between incidence and prevalence. The fresh water that is being poured through the tap is the flow of new cases. This fresh flow of water represents the incidence, consisting of the new cases adding to the total pool of cases. And prevalence, it is the total pool that has gathered in the bathtub. It consists of the new cases, the old cases, and only thing that is deducted from it is the loss due to deaths. So basically, in a stationary population in which there is no migration of cases or non-cases, if the incidence, prevalence and duration of a condition remain constant, then the number of new cases that occur must be balanced by the number of exiting cases that leave the population through death or cure. In such a situation, the prevalence is a function of the incidence and the average duration of being a case. And for a rare disease, prevalence becomes equal to incidence into duration. This P is equal to I multiplied by T. So coming to the uses of prevalence. Prevalence is based on both incidence and duration of illness. High prevalence of a disease within a population might reflect high incidence or prolonged survival without cure or both. Conversely, low prevalence might indicate low incidence, a rapidly fatal process, or rapid recovery. Prevalence rather than incidence is often measured for estimation of magnitude of chronic diseases which have long duration and dates of onset that are difficult to pinpoint. And it is also useful for identifying the high-risk groups. It also reflects the burden in terms of life expectancy, morbidity, quality of life, and many other indicators. And also found to be useful for planning and administrative purposes like hospital beds, manpower needs, that is inpatient analysis. So this takes us to another aspect of prevalence, interpretation of it. That is justifying the statement, improvement in treatment either decrease or increase prevalence of a disease. Well, with science and technology enriching the modern healthcare and the resultant improvement in treatment, there are perceptible changes in the morbidity as well as mortality of the diseases concerned. Improved treatment is ensuring there is increased number of recovered cases, decrease the duration of illness, resulting in decreased prevalence in some diseases. Whereas treatment may be such that by preventing death but not producing complete recovery, and hence it is leading to increased life expectancy in the morbid patients and hence causing a paradoxical increase in the prevalence of the concerned disease. Furthermore, if the duration is decreased sufficiently, a decrease in prevalence could take place despite an increase in the incidence. Well, that brings us to another applied question from this incidence prevalence and the case study designs. What type of epidemiological study is most appropriate to measure the cause-effect relationship of asbestos in respect to bronchogenic carcinoma and pleural mesothelioma among workers of asbestos industry? Give reason. Well, the epidemiological study that is most appropriate to measure the cause-effect relationship of asbestos in respect to bronchogenic carcinoma and pleural mesothelioma among workers of asbestos industry is cohort study, a type of analytical observational study undertaken to analyze association between suspected cause and effect. The reason why it's selected? Because cohort studies work from cause to effect, and here we need to assess the cause-effect relationship. And when we are studying the cause-effect in cause with two effects, case control study is not feasible. Cohort study is indicated when exposure is rare, but incidence of disease is high among the exposed. Here the workers in the asbestos factory are the spatial exposure group. Then the workers in asbestos factory comprises of a stable, cooperative, accessible study population who are available to follow up and hence ensuring minimal attrition of study population, satisfying another required criteria for cohort study. Next is the presence of good evidence of association between exposure to asbestos fibers to development of bronchogenic carcinoma and pleural mesothelioma as derived from clinical observations and all. So here all the workers in the asbestos factory are exposed to the common causative factor asbestos and hence form a homogeneous cohort. As epidemiological study of choice is of course a cohort study. Now coming to the oft asked question, steps of randomized controlled trial. First and foremost, there is protocol development. Then choosing the target population. Then from that, the study population who go through randomization into study group and control group. And there is manipulation, that is either addition or withdrawal of intervention. Who are followed up and finally assessed. And this protocol development has aims and objectives and standard working procedure spelled out. And when we are selecting the reference or target population, it is very important because this is the population on which the results would be generalized. Next is selecting the experimental population as mentioned, who need to give their informed consent and should be representative of the target population and should be eligible for the clinical trial concerned. And as we mentioned, next is the randomization. Randomization is often called the heart of a controlled trial. It is a statistical procedure by which study and control groups are allocated, eliminating bias and allowing comparability. And this is followed by manipulation, which involves a deliberate application, withdrawal, or reduction of the suspected causal factors. This is, of course, has a follow-up, which is examination at definite intervals under same conditions with equal intensity, same time frame till final assessment. And in this assessment, the outcomes are assessed in terms of positive or negative results. Bias may arise from the errors of assessment of the outcome, which may be having subjective variation, observer bias, or bias in evaluation. And as we mentioned earlier also, blinding techniques are adopted to eliminate the different kinds of bias, which may be single, double, or triple blind trials. So that brings us to the end of this part 1 of general epidemiology. As you all know, epidemiology is very vast, so it's very difficult to put it in one slide, put it in one go. So I have split it into two, and in the next part you'll find all the other important and relevant questions, very important from your exam point of view. So keep studying hard and all the best. Share, like, subscribe, and comment if you want to know anything or have any queries. So thank you so much.